How are seizures treated? Basically, there are four modalities now. You know, we spend almost our whole professional life learning about the meds. At this point, and this is going to increase, by the way, but there are four modalities. Anti-seizure meds, used to be called AEDs, but before that was called anticonvulsants. We talked about that. Dietary therapies, ketogenic plus others, surgical, and neuromodulation. The story with drugs is kind of like antibiotics. There's so many first generation, second generation. Now, of course, I understand that the United Nations is going to have a meeting about antimicrobial resistance in the world. We have kind of a similar issue. It's not as deadly as antimicrobial resistance, but our issue is more and more drugs haven't really changed the statistics on medical intractability. The newer drugs have certain advantages, maybe better tolerated, less drug interactions. They haven't really changed the efficacy statistics. So if you look at this overall timeline, it all started with bromides and Sir Charles Locock back in 1850-something. And then phenobarbital is the only one that we're still using, is the oldest of the ones that we're still using today in 1912. And then phenytoin, of course, with the great discovery of Merritt and Putnam right here at Boston City Hospital that's been well chronicled in books, et cetera. And then we get into some of the ones we're more used to hearing about, you know, primidone, not used much anymore. Ethosuximide is still the #1 choice for absence for most of us for various reasons. And then we get into valproate, which was a big splash, of course, when it came out in the mid-70s. Vigabatrin's been around a long time, but just kind of recently FDA approved. Still important for the use in patients with tuberous sclerosis with infantile spasms. Other than that, somewhat limited usefulness for various reasons, mainly the retinal toxicity. Zonisamide or Zonegran, lamotrigine, Lamictal, felbamate kind of had its splash in the mid-90s, and now it's just used for the most severe cases, although it can be remarkably effective. Gabapentin has had a better market for pain than epilepsy. Topiramate or Topamax has its own issues. And then some of the newer ones that you know about tiagabine hasn't really caught on in pediatrics. Oxcarb, of course, is a major player in trileptal. Levetiracetam has had probably the most impact on our daily practices. Keppra, it's just wide spectrum. It's safe. It's got the problem with anxiety and psychosis, but it's been a major player, and available IV is helpful. Stiripentol is still not available in the United States, but is very helpful in Dravet syndrome, where all the hype is with the medical marijuana right now. But once that hype dies down, we'll go back to stiripentol, is my view on that. I realize that was an editorial. Pregabalin hasn't really caught on. Rufinamide or Banzel actually has been helpful for the Lennox-Gastaut kids and some of the Dursa kids, otherwise mispronounced as Deuce. Lacosamide or Vimpat's been a major player, now available IV, of course, that helps. Eslicarbazepine still remains to be seen how helpful that's going to be. Perampanel came out since this, which is unique because of its anti-glutamatergic action. May have a role, but I think a minor one for us right now in pediatrics. One of the biggest disappointments is ezogabine, because it's a potassium channel opener that could help kids with bad epilepsy from KCNQ2 mutations, but it caused that bluish discoloration of the eye, caused a lot of urinary retention, and the drug company recently announced that they're going to discontinue producing it, not because of the side effect profile, but because there's not a market for it. So that one we're going to lose our access to ezogabine. What's the other name of ezogabine? I'm blank. Retigabine, sorry. In case some people use the other name. Big problem with our seizure drugs hasn't really changed. This is the classic paper from Kwan and Brody, which was adults and kids. Kids are actually a little better than this, but basically about maybe up to half of people are seizure-free with the first drug. But when you add the second drug and the third drug, the benefit goes down each time, and about a third of patients, in pediatrics a quarter of patients, are medically refractory. So we try other things. Try diet, low-carbohydrate diet, talk about surgery. Neuromodulation, the newest agent here that's pretty promising is this RNS, so does NeuroPace, where this device is implanted in the brain with two different sites, and it senses a seizure coming. It does remarkable long-term EEG recordings, and it gives an electrical impulse at the beginning of a seizure, which can therefore abort the seizure. This is not FDA approved at the moment in patients less than 18. And the biggest limitation for us is once you have one in, you can't have an MRI in the future. That's a big limitation, at least an MRI of the brain. And then there are other sites of stimulation that we'll hear about. So, epileptogenesis. It can be generalized, it can be lobar, it can be multifocal. A lot of times when we're planning epilepsy surgery, we'll talk about zones and networks. The epileptogenic zone is an important concept in epilepsy surgery planning. It's this kind of abstract concept. It's defined as the smallest but indispensable area to remove to get rid of seizures. But it may or may not overlap with a whole bunch of different zones that we talk about, like the irritative zone where the spikes are, the lesion that you might see, or you may not see on an MRI. The zone is an abstract concept, actually, but we're always trying to find it. And then the network is defined as connected areas that where one part affects another. There was this old concept from Wilder Penfield himself called nociferous cortex, which means one part of the cortex is harmful to another. And that's where we get into the whole network theory of epilepsy. And if we can disrupt the network, even if we can't remove all the bad areas, sometimes we can do so good. Even though in general, if a patient has dysplasia, the best surgical outcome is associated with the most complete removal. So we use a lot of modalities when we evaluate patients for something like epilepsy surgery.